Hello, and welcome to Stop HIV, Screen, Treat, Overcome, and Prevent PrEP Care on Demand. I'm your moderator, Rachel Deer with DKB Med. Thank you so much for joining us. I'm happy to introduce our esteemed faculty, Dr. Augustina Boehringer, Chief Medical Officer at Heart to Heart International, and Ryan Pasternak, Division of Adolescent and Young Adult Medicine at Children's Mercy, Kansas City. Dr. Boehringer, Dr. Pasternak, thank you so much for being here.
Thank you so much for having us.
Excited to be here. Thank you.
And I'd like to introduce our patient faculty, Alexander, Deja, and Fidel. Thank you so much to the three of them. You'll be seeing them in a couple of videos throughout the presentation. This program has been supported by an independent educational grant from Gilead Sciences. All activity content and materials have been developed solely by the planning committee members and faculty presenters. And now I'll turn it over to Dr. Boehringer.
So before we start the program, we are going to have a short pre-test, and you're going to see these questions again. So we'll start with question number 1. Which age group has the lowest proportion of PrEP prescriptions relative to the indications for PrEP? A, under 25 years. B, 25 to 34 years. C, 35 to 44 years. D, 45 to 54 years, or E, 55 and up.
How does cultural humility differ from cultural competency? A, cultural humility emphasizes concrete, finite facts about various cultures. Cultural competency focuses on ongoing learning. B, cultural humility involves ongoing self-reflection. Cultural competency involves knowing the values of different cultures. C, cultural humility encourages believing and knowing all there is to know about diverse cultures. Cultural competency emphasizes empathy and equality. Or D, cultural humility prioritizes working collaboratively. Cultural competency focuses on addressing inequalities.
And question 3, which of the following is a contraindication to PrEP? A, current injection drug use. B, pregnancy. C, reactive HIV test. D, hepatitis B. Or E, use of feminizing hormones.
We have a number of learning objectives today. The first is to describe the risk of HIV in adolescents and young adults, to evaluate the benefits and tenets of practicing with cultural humility. Last, to define eligibility and contraindications for use of PrEP, pre-exposure prophylaxis for HIV. And now Dr. Boehringer is going to do an HIV overview.
Thank you. So we'll start with the epidemiology of HIV with data from 2021. There are 1.2 million people living with HIV, 21% of whom are 34 years old or younger, 79% of whom are male at birth, and 13% of whom are unaware of their diagnosis. On this slide, we can see the 3 different pie charts that break down the new diagnoses of HIV infection in 2022. The first pie chart describes the breakdown by age. And as you can see, 56% of new diagnoses occur in people under 35 years of age. And we will compare how that goes hand in hand with also a section of the population that tends to be under-prescribed PrEP. The center pie chart breaks down the new diagnoses by gender. So the majority of new diagnoses are in men. A small percentage are in transgender women, and then 18% are in cisgender women. And then the last pie chart detail the mode of transmission. So men who have sex with men, heterosexual sex and injection drug use. And in this bar graph, we can see as well the trend in the number of new diagnoses in each year. And we can see that although there was a dip in 2020, it has remained fairly consistent. When we talk about the significant variation in the incidence of HIV, it is difficult to ignore that Black and African American individuals are significantly more likely to be diagnosed with HIV, as you can see by these numbers. And when we talk about HIV prevention and how those disparities affect HIV diagnoses, you can also see here how with proper prevention and access to prevention, significant improvement can be made in, or a decline in new HIV diagnoses. And again, here we have them represented by race as well as by year, with the most recent data being from 2021. This slide shows us the lifetime risk of acquiring HIV. The top half of the slide represents the risk based on race and gender, where the bottom half of the slide shows us race, but specific to gay, bisexual, and other men who have sex with men. And as you can see, it is quite clear that Black, gay, bisexual, and other men who have sex with men have by far the largest or the highest lifetime risk of contracting HIV. When we talk about HIV prevention, we have to talk about sexually transmitted infections in general, as we know that chlamydia, gonorrhea, and syphilis do carry a higher risk of contracting HIV for a variety of reasons that we will discuss in an upcoming slide. But this graph here shows us over the past few years the incidence of chlamydia, gonorrhea, and syphilis. And with syphilis specifically, you can see that there is a significant increase over the past few years. So as I was mentioning, STIs in general share causal pathways with HIV, and this is why that relationship is so important to highlight. The STIs increase leukocytes at the anatomic sites of HIV exposure, and so this disrupts the mucosa and makes it more susceptible to HIV. A case-controlled study of about 880 clinic visits showed that rectal STIs are independently associated with HIV acquisition. So that's a pretty convincing study. So the elevation is 3.8 times higher, the risk of new HIV diagnosis in the 12 months after somebody has been diagnosed with a rectal STI. So now that we had a little bit of an overview about HIV and touched a little bit on other STIs, we're going to talk specifically about HIV testing. And so I'm going to pass it back to Ryan.
Thank you, Agustina. So I'm going to talk briefly about HIV testing. First, we'll watch a video that looks at young adult knowledge about HIV testing.
I learned about HIV and STIs after high school.
When I first became sexually active, which was in my later years of high school, I was never tested. I didn't think about getting tested.
Sexual health wasn't really a hot topic. Sex in general was for marriage. I did go to a private school, so you could only imagine the type of sexual health education I got.
You know, with the lack of knowledge and education, I had no idea how prevalent it was, how relevant it could be. And again, that gave me that mindset of like, oh, like nobody's really talking about it. Nobody's teaching me about this. So, like, I'm seeing it on social media, but it can't be that big of a deal, right? If nobody's like actively telling me like, hey, this is something that you should be looking out for.
As somebody who's a part of the LGBTQ community, and you are also a person of color, it is very important that you take your health very seriously.
my knowledge was super limited, and all I knew was that they were diseases that you could contract from doing any sort of sexual act with somebody if they had something, and you should just be safe by either not doing it or wearing a condom or whatnot.
And every time I would look into it and I would say, okay, well, maybe if I had PrEP, I wouldn't have to worry so much.
4 years after knowing about PrEP, hearing about PrEP, um, there was a study opportunity specifically for trans women who were on hormones and who wanted to start PrEP. And that was my ticket into starting PrEP.
So wow, those stories are pretty compelling. And I don't know about you, Augustina, but for me, the thing that I really took away from each of those young person's stories was how little information they had at a critical time when we as clinicians oftentimes worry about HIV and other STI acquisition, and also just how long we've had guidelines out that have recommended universal screening as early as age 13 for young people. And they didn't know, right? They didn't know that screening was recommended necessarily. They didn't know that they had options for preventing infection.
And the fact that they interpreted not receiving information as it must not be that big a deal, right? Like if nobody's talking about it, then I probably don't have anything to worry about, or it's not, it shouldn't be top of mind. And one of the video participants mentioned, maybe if I was on PrEP, I wouldn't have to worry so much. And that makes me think of harm reduction, because when we hear about how sexual health is taught, many times it's pretty black and white. It's like, well, the only way to avoid STIs is to practice abstinence or to always use a condom. And certainly that is ideal. Using a condom for any contact is ideal, but in real life, that's not how it happens. And so I think that, if we can reduce the risk of at least one STI in people who choose to not use condoms by prescribing PrEP, then that's a golden opportunity right there.
Okay, so now I'm going to talk a little bit about HIV testing and current CDC guidelines for HIV testing. So as I just mentioned, all persons ages 13 to 64 years of age should be screened for HIV at least once. So this is a universal recommendation that's existed for quite some time, and something that in my practice I use pretty consistently to tell patients and even parents of young teens that this is a universal recommendation. It's not based on their behaviors or experiences. Certainly, if we have someone that we're concerned is at risk, we want to test and screen them too. Anyone that's starting treatment for tuberculosis, anyone that's seeking treatment for sexually transmitted infections, of course, we want to ensure that we do HIV testing. And then persons at higher risk for infection, men are having sex with men, persons using injection drugs should be screened at least annually, with consideration for more frequent testing, oftentimes every 3 to 6 months, depending on individual risk factors. In our clinics with adolescents and young adults, we typically do screening every 3 months, consistent with recommendations for other STI screening. And then anyone with symptoms or signs consistent with an HIV infection or an opportunistic infection that could be indicative of existing HIV infection. And then anyone who requests a test should be given a test without the need to disclose any exposure or meet some specific risk threshold. So this slide looks at the percent of persons with HIV infection that have knowledge of their status. And we can see that for 13 to 24-year-olds in particular, only 56% of those infected with HIV were aware of their status as being HIV positive. And 44% of people under 25 with an infection were unaware of their status. One of the contributors to getting screening, being tested, and knowing your status is a lack of access to routine healthcare. So we recognize that this exacerbates deficits in HIV screening, prevention, and treatment. not having a usual source of medical care. So we recognize that there are significant disparities when it comes to having no usual source of medical care. And we can see in this slide that Hispanic adults particularly are at significant disparity, with 34% indicating that they had no usual source of medical care. And here, looking at this overlap between populations, by age, 18 to 29-year-olds, 45% indicated they had no primary care clinician. And for 20 to 29-year-olds, 34% with a new HIV diagnosis. So there's concern that there is this overlap between persons with a new diagnosis and a lack of access to services. And so one of the ways in which we want to practice is in what we call a status neutral care continuum. So we want to offer HIV testing to everyone. And we want to interpret that testing and work with patients based on their results. But again, destigmatize testing and screening by offering it consistently. So if someone has a negative test, that's an opportunity to offer prevention for HIV or PrEP, pre-exposure prophylaxis, continued participation in care and prevention, and then reducing the risk of HIV, and then following up, as I mentioned before, with repeat testing on a cadence that's appropriate for them. Someone tests positive, then we can get them into antiretroviral therapy quickly. That's effective, recognizing that becoming undetectable with the use of antiretroviral therapy means they're also untransmittable. They're not likely to transmit the infection to others. We want to have them remain in care or have retention, and then again, work towards viral suppression with treatment. So having that test done, doing an HIV test spurs action regardless of the result. And we want to really normalize testing and prevention, which destigmatizes both. And this helps to address the needs for all of our patients across an entire population, regardless of their HIV status. Screening for HIV. So the gold standard is laboratory-based screening. So a fourth generation, what we call P24 antigen and antibody test, is used for routine screening. These are widely available now, but patients have to come back for results. They may have to follow up or call within several days. Rapid HIV tests have several advantages. We've used these in many clinics that I've worked in, including school-based health clinics and adolescent and young adult specialty clinics. Oftentimes, these are either oral or finger stick-based testing with results within a few minutes. It increases access to prevention and intervention and screening. Minimal to no equipment or skill is required, but rapid tests may miss recent or acute infection. So you may need a confirmatory test for any positives, or if there's a high suspicion or likelihood for infection, you might want to check for a viral load or follow up with one of the gold standard tests.
Thank you, Ryan. So let's talk about cultural humility. And to start the conversation, why don't we watch the following video together?
I was like maybe 8 or 9, or maybe 10, living in a different state. And my mom had to literally vouch for me to be seen by the doctor just because I didn't have health insurance. And they assumed that we couldn't pay because of our skin tone.
I think it would have made a huge difference for me if my health provider from the beginning was, more welcoming, more opening, and willing to have those discussions, or even just bringing it up like in the slightest bit. But I never got that. So, I was left unaware and I didn't care.
I think taking cultural humility into account is going to be a great thing, because it's going to build a bridge between you and your patients. Having a better understanding of the struggles and challenges that they might face on their day-to-day are very separate from another patient who might have the same diagnosis or issue. I think thinking about the person, the individual.
But I generally like to see healthcare providers that don't see color or race, don't see a sexuality, don't see a disease or pretty much anything as like a problem.
I think, physicians, healthcare providers taking the time to slow down and engage with their patients would be beneficial, even though they are, very busy, because, sometimes the when you think about the white coat, it could be very intimidating.
I think it's almost the baseline that all healthcare providers should be, very aware of their patients in terms of like their culture and their background and any biases that they might have. Because at the end of the day, these are healthcare providers for the community. And that community is not just one specific type of person, one sexual orientation, gender, whatever it may be.
The fact that my healthcare provider now has taken the time to do research and know about programs and know about ways around getting medication, it's really eye-opening. And it was a very heartwarming experience to know that things like that existed.
I think it's really about creating that air of trust, with the doctor. Because after that, if you don't have that, then there's just no relationship at all.
And we want young people, all people, to be as powerful as they can be. And so when we think about that, we want definitely meet them where they're at. I don't even like to say meet them halfway, because sometimes their halfway is different than your halfway.
It comes back to meeting your patients where they're at. That last statement about it's not necessarily halfway. It's us having to meet patients where they're at.
Yeah, I loved that because, sometimes it's 80% of the way, and sometimes it's 10% of the way. I think we've all by now heard of the concept of cultural competency, but cultural humility it goes beyond that, right? So competency has a very finite sense to it. It's like we're used to studying and we learn something and now we're competent and we know how to do it and that's it, we're done, right? But humility involves a lot more than just the knowledge. The knowledge is hugely important, right? But the ongoing learning, the being vulnerable, as we can see here on this slide, understanding that just because you know about a culture doesn't mean, or a community, it doesn't mean that you're able to empathize with it. And so having that constant critical self-reflection, this is an important concept, is what moves us from just being culturally competent to being culturally humble. In both of those, we want to stress working collaboratively with our patients and working with our differences and addressing inequalities and inequities. I think, quite frankly, there is a lot of medical mistrust in certain communities. And honestly, a lot of that is for good reason. And I think if we just discuss this with patients, it creates a much more trusting relationship for the patient and for us. This slide talks a little bit about what that Venn diagram was saying in a more graphic way, but essentially, greater self-awareness, hopefully reducing the effects, the stressful effects of being a member of a minority population, whatever population that may be, and understanding that I can't tell you how many times I've had a patient that said, oh, I haven't been to the doctor in however many years because the last time I went, I had a bad experience regarding, my gender, my race, my sexual orientation. And so that's where that self-reflection is critical, because we are all human, we all make mistakes, but being unaware of that can have this domino effect where the person that we're interacting with then is sort of turned off from the medical establishment as a whole, and that can have very serious consequences. Ryan, have you had any Any patients that have shared something like that with you?
Yeah, in fact, just yesterday, seeing a patient, um, they shared with me after the visit with an unexpected hug, that they had had some pretty negative experiences in the past. And one thing that I've found myself doing, and I say this to the patient, but I'm really saying it to reinforce it to myself, so that I am just a little more conscious and aware of any biases that I might be bringing in, is particularly with adolescent and young adult patients that I might spend some time confidentially separate from a parent or something. I let them know at the beginning of that time that, my job is not to judge them, my job is not to lecture them, but it's to provide illicit information, provide medical information, give them some choices and options, and help them work towards meeting their goals, whatever those goals may be. And that goal may be to start something like PrEP to reduce their risk of HIV, or it may not be. But it's not for me to sort of judge or decide. It's also not for me to judge or decide if their behaviors are, right or wrong. I just need to acknowledge that those behaviors may relate to other risk factors that we want to address and see how they want to respond to that. So I usually say that. I say, I'm not here to judge you. I'm here to elicit information, provide you medical information back, give you some choices or a menu of options to choose from, and you decide what works for you to meet the goals that you stated. And I think that, again, I'm reflecting on that as I'm saying.
Yeah, and you hit most of these 5 R's that we talk about in cultural humility: reflection, respect, regard, relevance, and resiliency. And we will talk about tips and tricks on how to have these conversations with patients a little bit later in the program. But I love what you mentioned about respecting people's decisions and choices, even if they're not what you would ideally like to see them doing. And we focus on harm reduction. There's not necessarily harm elimination, but I've actually had patients tell me that another provider was withholding PrEP or sort of using PrEP as leverage to, well, if you're not going to use condoms, then why bother with PrEP? And I don't think PrEP should ever be a bargaining tool, because it's not perfect, but it's certainly much better than not having PrEP.
I agree.
Do you want to talk a little bit, since we started on the topic, about building trust with patients, because that's what this is all about, right?
Yeah, I think in the first bullet here is about examining personal bias and paying attention to your prejudices. So again, that's why, in large part, I say the things that I say before I start to talk about some of these sensitive subject areas, because I recognize that I grew up in a different time. I had a specific upbringing, and I want to meet the patient where they're at, not where I'm at. And so I need to examine those personal biases and recognize when I may have negative attitudes that could impact my delivery of care, and address those. And then, being aware of microaggressions that either I'm causing or even staff. And that's something that we talk about with our staff quite a bit, about how, and they are pretty open about it too, about how they feel about certain situations and patients, and how we want to, again, support the patient. And that's our goal. Are there things that you do in practice, Agustina, that you think help you build trust with patients?
I think the key one, you mentioned it as well. I work with some adolescents, but the primary sector of my population are adults. Especially when we start the conversation about PrEP or sexual health in general, I'm quite honest and say, listen, I'm going to ask you a lot of questions that may feel pretty invasive. And like you said, Ryan, I make it very clear the reason is not because I'm curious, because I'm ghoulish, because I'm a weirdo, or because I'm here to judge what you choose to do. But it's because certain things, first of all, I want to get to know you better and I want to understand you. But, certain things carry certain risks. And, like when we ask about what body parts do you use for sex, because those things make a little bit of a difference in how we approach. So just being very, very frank, and just sometimes acknowledging that the first conversation, especially in the urgent care setting, which is where I started doing PrEP, I'm not your primary care provider, and we don't know each other. And here I am asking you what body parts you use for sex. So I think acknowledging, hey, I know this might feel awkward. I don't feel awkward, so hopefully you don't feel awkward, but if you do, that's okay. And also that if there's questions that you don't want to answer, again, I'm not going to withhold PrEP because you didn't want to tell me something. So for the most part, once patients understand that we're a team and I'm here to perform harm reduction and to keep people healthy to the best of our ability, then things start to build. And then we do end up having a relationship, even though it's urgent care, because they tend to come back for their PrEP appointments. And that's where that trust really grows, because it can be hard as the one-off provider to build that same dynamic that people can have with their primary care provider. At the same time, I have patients that go to urgent care because they are not comfortable having these conversations with their primary care provider. So there's a little bit of both there.
I can imagine. And, you mentioned something, just the asking about the body parts question, and that can be really important medically, right? We need to know that information. Medically, the CDC says that we should provide STI testing at all exposed sites. But also we want to destigmatize that, right? It's not my job to label you. I actually try not to use the term MSM in my notes or charts, because patients may identify in a specific way, and they may use their body parts in a specific way. And really for us as clinicians, it's really about what body parts went where and how do we counsel.
I made that mistake early on in my own PrEP journey of prescribing PrEP to patients. A gentleman mentioned that he wanted PrEP because occasionally he had sexual encounters with men. And later on, when we were talking, I made the mistake of assuming, and we all know what happens when we assume. And I said, oh, and for bisexual people, blah, blah, blah. And he took great offense. He said, I'm not bisexual, I'm heterosexual. I just sometimes have sex with men. And I remember thinking, I'm a dummy that I went there and I assumed something, and I used a term that he didn't tell me that's how he identified. So I learned that lesson early on, that, certain behaviors and certain body parts don't equal a definition that we may have thought it equaled. And so just listening to our patients and using whatever terms they use to define themselves, because they are the experts on their own body and on their own selves.
And one way that we can be culturally humble or practice cultural humility as providers is to use different models to engage our patients. This is the SIEO model. The S stands for sex assigned at birth, the I for gender identity, the E for gender expression, and the O for sexual orientation. And as Agustina and I were just saying, as healthcare providers and clinicians, it's really important for us oftentimes to understand what body parts our patient has and what body parts went where during sexual experiences for patients. So understanding their sex assigned at birth is a first step there. Gender identity can be really important for patients, and respecting patients and their gender identity, and also acknowledging pronouns and other aspects of their gender identity can be very important. And then gender expression, things like femininity, masculinity, whether they feel like they're femme or butch, and then sexual orientation. But as we were just saying, labeling with a specific sexual orientation can also be risky. We don't want to be the ones to label our patients. We want our patients to tell us who they are and how they are with other persons from a reproductive and sexual health experience. So starting the conversation with patients in urgent care or convenient care settings, we want to have this conversation with any patient seeking testing or treatment for STIs about STI screening, testing, and use of PrEP. In primary care, we may have this conversation with all patients at some point, particularly at well exams or acute care visits that might be related to sexual health. We want to consider bringing it up in sexual health, bringing up sexual health in less obvious cases. So if someone has a sore throat, it could be strep, but oftentimes it could also be an STI. And this is a conversation that we just had with a patient yesterday. Augustina, have you ever, or how do you bring that up? That's a really good example about a sore throat. How do you bring that up with patients in an urgent care setting that this could be an STI like laryngeal gonorrhea?
Yeah, so that is, it's part of the differential diagnosis, and I try to stay away from using very, from using lingo such as saying differential diagnosis. And I'll explain to patients, like we've ruled out the more common things. So maybe we tested for strep, or maybe we don't think it's mono for whatever reason. And I'll say something like, another thing that this could be is a sexually transmitted infection. Do you mind if we talk a little bit about how you have sex and with whom you have sex, in case that's what we're looking at here?
So there's some examples here of ways that you might ask these questions or begin the conversation. So if I may, I'd like to ask you some questions about sex. I understand these questions may make you feel uncomfortable, but they help us determine how to best protect your sexual health. I think the next one, I ask these questions of all my patients. The one thing I've always said to all students and residents that I've trained over the last 20 plus years is that if you ever use this phrase, honor it and ask all your patients these questions. Patients can tell if we're comfortable or if we're not comfortable in a subject area. And if we're sort of stumbling around asking a question that we say we ask everyone, that may erode trust in and of itself. So just be consistent. And then another way to start the conversation is asking about the 5 Ps, and those include partners, practices, past history of STIs, protection from STIs, and pregnancy plans. So each of these contributes to our sexual history for a patient, asking about the partners they have, their assigned sex at birth and body parts, gets into practices, past history of STIs. Again, Agustina mentioned earlier the relationship, the very strong relationship or correlation between a history of a bacterial STI or syphilis and the increased risk of HIV acquisition. And we also have to remind patients sometimes that having had or being at risk for other STIs also means that you're likely at risk for HIV. And then what are they doing to protect themselves from STI acquisition? And then pregnancy planning. So again, all of the things we're talking about while we're talking about PrEP and HIV, it's all part of family planning as well in some cases, and in reproductive health planning. So we want to honor our patients' goals in that regard as well. And next, we'll talk a bit about pre-exposure prophylaxis, or PrEP. So the most important thing to understand about PrEP is that it's highly effective. So pre-exposure prophylaxis for HIV, or PrEP, reduces risk of HIV acquisition from sex by about 99% when taken as prescribed. It also reduces risk of HIV among people who inject drugs by at least 74% when taken as prescribed. Those numbers are well beyond the efficacy rates for many medications that clinicians prescribe on a daily basis. It does not protect against other STIs, though, and discussing that with patients is important. So when should PrEP be considered? One of my colleagues does a great talk on this, and her talk is called All Roads Lead to PrEP. So the most important thing to understand is that whenever someone requests pre-exposure prophylaxis or PrEP, even without disclosing a specific risk, we should honor that request and provide a prescription based on other criteria. But we do not need to have a specific criteria or risk stratus for them to meet before prescribing the medication. So if they have a recent diagnosis of an STI or a request for STI testing in the last 3 to 6 months, that would be a great time to talk about or consider PrEP. Inconsistent or infrequent condom use, recent post-exposure prophylaxis or NPEP, non-occupational HIV post-exposure prophylaxis, or multiple episodes of needing or using post-exposure prophylaxis for HIV. If they request HIV testing, that might indicate that they have a concern that they may be at risk for infection. And so that's also an opportunity to consider PrEP. If they know that their partner has HIV, or they're in a non-monogamous relationship, or concerned that their partner has other partners as well. Sexual activity in high prevalence areas or networks. So I lived and worked in New Orleans and Louisiana for many years, and our STI rates and HIV rates in that city and in that state were significantly higher than other places in the country. And so oftentimes we recommended, given our patients that were having sex had a higher risk, we recommended them to consider PrEP. Transactional sex, sex for money, drugs, rent, etc. Use of drugs or alcohol, especially if they're using drugs or alcohol in the context of having sex, which we know can negatively impact decision-making at the time of sex, which might lead to lack of consistent condom use, etc. Use of injection drugs themselves, recent history of incarceration of the patient or themselves or a partner. And then again, anyone who asks for PrEP should be able to receive a prescription for PrEP. Options for PrEP that are taken orally include Truvada and Descovy. So for each, there's a recommendation to evaluate creatinine clearance or renal function. There's a small risk of kidney or bone toxicity in the first option. And this has also been an option that's been studied for what's called on-demand PrEP or PrEP 211. And that's been studied for use in gay and bisexual men who are having sex with men and transgender women in a small trial that showed efficacy with that on-demand use around the time of sex. It's proved for use for all at-risk populations and demonstrated safety when used in pregnancy, and there's now a generic version. For the second option, again, creatinine clearance is evaluated, but there's fewer in bone and renal toxicity indications, small increase in LDL and weight, not been indicated for prevention of HIV from vaginal sex, so this is being studied, and a smaller pill size for the second option. There's also cabotegravir or Apretude, which is a long-acting injectable version of PrEP. This was approved in 2021. It was approved for all at-risk populations over 35 kilograms with minimal drug-drug interactions. Some of those included anticonvulsants and antimicrobacterials. The common side effects were injection site reactions and fatigue. This is taken as an IM injection every 2 months after 2 monthly doses and given by healthcare providers. There is an option for an oral lead-in.
Several trials of subcutaneous lenacapavir every 6 months are ongoing. Interim results of the Purpose 1 trial has showed twice yearly subcutaneous lenacapavir demonstrated 100% efficacy for preventing HIV in cisgender adolescent and adult women. Lenacapavir was well tolerated with no significant or new safety concerns, so we look forward to results of the other Purpose trials in different populations.
Contraindications for using PrEP include active current HIV infection. So PrEP agents do not meet the needs to complete HIV treatment. They are not antiretroviral therapy for someone who is known to be positive. So we try and confirm HIV status with one of those HIV antigen antibody tests that I mentioned earlier before starting. So if someone has an HIV infection and it's known, or they have a possible HIV infection because they have signs or symptoms of acute retroviral syndrome or recent high-risk exposure, in that case, you may want to check a viral load. If they're underweight, I have had this happen with some patients, rarely, where their weight with other medical conditions is quite low, or if they have evidence of renal insufficiency that's existing. Augustina, I wanted to ask you about some of these things and how you manage that in an urgent care setting and manage that initial evaluation.
Yeah, so I think it's important to say again that really the only absolute contraindication for PrEP is existing HIV infection, right? And that's why that test is paramount to starting PrEP. Having said that, we also want to be able to do an expeditious prescription of the medication, or sometimes even send people home with some samples. So what I typically do is I do a point of care test, which is not the end all be all of testing, but just to give me an idea. Obviously, we discuss any possible signs and symptoms that could be active HIV or recent HIV infection. We talk about recent high-risk behaviors, do the point of care test, and then send the fourth generation test out to the lab, which with our lab takes 24 hours. I still send people home with PrEP that same day. Obviously, if the point of care came back positive or I had a high index of suspicion, I wouldn't. But otherwise, we send them home with PrEP. And I explain, like with everything, I think the more you talk to your patients, the better that relationship becomes. And I explain, look, if your test for HIV is positive, you can't stay on just this medication. That is a contraindication. It could actually harm you. You could develop a resistant strain of the virus, and you would need additional medications. And so I've actually, knock on wood, only had 2 patients that whose test came back positive so far, and they had no problem. They understood they don't want to cause harm to themselves, and we were able to refer them to receive full ART, which PrEP is certainly not.
We follow a similar sort of algorithm. We try and do the testing. If the patient came into the morning clinic, we may get the test result back that day or that afternoon.
Right.
And otherwise, we're going to get it back probably before lunchtime the following day. And we do try with all of our patients, really, for every visit, but I think we're particularly diligent. It's part of our algorithm for PrEP prescription is to just verify their phone number, to also really strongly encourage patient portal sign up, and just have as many routes of access to contacting the patient as possible. Absolutely. Those are very important points because we all have had patients who are lost to follow up, and we don't want the PrEP patients to be that. Yeah. And leave the clinic with a prescription. And then we want to confirm eligibility for PrEP. So again, ideally, we're documenting a negative HIV test within 1 week of prescribing. But as mentioned, we typically will provide the medication the same day. No signs or symptoms of acute HIV infection, no contraindicated medications, which there's a link here to give you a list of those. And then estimated creatinine clearance that's greater than 30 for oral PrEP, which we can get on basic labs that typically come back pretty quickly. So if you're going to do same-day PrEP initiation, again, we have to do that point-of-care HIV test, which we do use. Typically, we don't want to use the oral rapid HIV test. The antigen antibody test is preferred. Pregnancy tests for those who may be or may become pregnant. Drawing blood for the creatinine for oral PrEP options and HIV testing. Following up quickly if the lab result indicates that they do have HIV infection or renal dysfunction, and then providing scheduled follow-up care and having the ability to contact patients. The lab results indicate the need to discontinue PrEP, basically because they have HIV or because of poor creatinine. So the goal is 50% coverage for PrEP. This has shown that we've had a steady increase, but we have a ways to go. And then disparities in PrEP coverage by age. So of the 1.2 million people who would benefit from PrEP that are estimated to be there in the US, only 36% were prescribed PrEP in 2022. Only 24% of young people who could benefit from PrEP were prescribed PrEP. So again, patient population that I take care of, adolescents and young adults, tends to be trailing behind. And oftentimes this is when patients are initially infected with HIV. So it's part of our goal to try and increase screening and then increase PrEP utilization for those patient populations. Only 13% of Black individuals who could benefit were prescribed PrEP. So again, this shows that 94% of white individuals that were indicated as eligible were receiving it, but only 13% of Black and 24% of Hispanic and Latino individuals. So again, that's a huge disparity where populations that might be at greater risk that we showed in earlier slides are really lagging behind in this receiving effective medications for prevention of HIV. All right, and this chart from the CDC shows the screening baseline labs as well as the every 3, 6, and annual month and annual labs for persons using oral PrEP. So at screening, everyone's going to get screened for HIV with an antigen antibody test. We want to estimate creatinine clearance, do syphilis, gonorrhea, and chlamydia screening as part of your routine STI screening. Hepatitis B screening is still recommended for persons using oral PrEP. And then hepatitis C screening for men who are having sex with men or people who inject drugs. And then pregnancy testing for persons with childbearing potential. And then you can see that there's recommendations to follow up screening for HIV every 3 months and then annually, and then syphilis, gonorrhea, and chlamydia testing for men who are having sex with men and transgender women. In our adolescent health clinic, we would do that testing for anyone who's still having sex every 3 months as per CDC guidelines. Persons using injectable PrEP, again, we're going to do those same initial STI screening tests, including HIV, syphilis, gonorrhea, and chlamydia at the first visit. And then we're going to continue to follow HIV screening at the 1 month visit, and then every 2 months for this 2 month, 4 month, and 6 month visit, and then annually thereafter. And again, for prescribing PrEP, if we're looking at oral PrEP options, we want to confirm with an antigen antibody test that the patient is not infected with HIV. The prescribing interval is generally every 3 months. And we're going to retest for HIV with that antigen antibody test and HIV RNA every 3 months, assess for signs and symptoms of acute HIV, assess for adherence on an every 3 month basis, and then also do STI testing, including 3-site testing. In other words, oral, urethral, or vaginal and rectal screening if needed, and then creatinine clearance and lipid testing for oral PrEP options, and then injectable PrEP, as I mentioned in the last slide. PrEP can be expensive for patients that don't have insurance or there are other coverage limitations. So most insurance plans and state Medicaid will cover some options for PrEP. Prior authorization can be required. Ready Set PrEP provides PrEP to people with no medication insurance. So there's a number and a website here, and there's copay assistance from Gilead and Vive Connect for patients as well. If a patient does test positive for HIV, we want to recommend that antiretroviral treatment that is recommended for everybody to reduce morbidity and mortality for the patient and prevent transmission to other persons. So again, we recommend initiating antiretroviral therapy immediately as soon as possible after diagnosis to increase the uptake of the medication linkage to care, decrease time to viral suppression for individual patients, and improve the rate of virologic suppression among persons with HIV, which again improves the health of that individual patient, and reduces likelihood of transmission to other persons. If you're not comfortable managing HIV, you can refer your patient to an experienced HIV specialist or initiate treatment and provide a warm handoff to an HIV specialist. And it is important to identify HIV specialists and referral pathways in advance.
And I'll add, Ryan, if I may, that it is especially important for patients who have seroconverted after having been on the injectable PrEP, because that particular medication poses a higher risk of integrase resistance. And so, having some guidance if you're not an HIV provider or you're not comfortable with initiating that treatment, it has to be very, very quick.
All right. So back to the goals of treatment. The first goal of treatment for a person with HIV is to achieve viral suppression, which restores and helps preserve immunologic function. We want to reduce HIV-associated morbidity and prolong the duration and quality of survival for the patient. We recognize that patients with this infection can live very long and fulfilling lives. Prevent transmission to others, again, recognizing that undetectable equals untransmittable. Immediate antiretroviral therapy initiation on the day of diagnosis. Again, some folks don't engage in care between initial diagnosis and the time antiretroviral therapy is eventually prescribed. So rapid antiretroviral therapy initiation increases uptake of the medication. Engagement in care accelerates that time to viral suppression. Post-exposure prophylaxis, or PEP and NPEP, both PEP and NPEP occur after potential exposure to HIV. Within 72 hours of exposure, patients requesting NPEP may be good candidates for PrEP as well. PEP and NPEP consist of a 2-medication regimen taken for 28 days. That includes tenofovir, amitriptyline, plus raltegravir or dolutegravir. So some key takeaways from today. The first is that PrEP reduces risk of HIV by 99% when taken as prescribed. It is indicated to prevent HIV via sexual transmission in adolescents and adults. PrEP should be considered for all sexually active adolescents and adults. The only contraindications to PrEP are HIV infection or weight less than 35 kilograms, recent STIs, or requests for tests for STIs or HIV should trigger a discussion of PrEP. PrEP is underprescribed to young people, with only 24% of people under 25 with an indication for PrEP receiving it. And this age group is the lowest for PrEP coverage. Also, PrEP is not prescribed equitably. Only 13% of Black individuals and 24% of Hispanic individuals with an indication for PrEP receive it, compared to 94% of white individuals. Cultural humility involves ongoing self-reflection. We can foster positive intercultural relationships and engagement with patients. And we in urgent and convenient care settings are poised to assess patients for PrEP eligibility, to prescribe PrEP to patients who may benefit from it and may not have a primary care provider. And PrEP is indicated for any adolescent or adult who asks for it.
All right, so that concludes the presentation of the program. And so now we're going to move into the post-test. So these are the same questions that you have answered in the beginning, and we're going to go through them again. Question 1, which age group has the lowest PrEP coverage? And this is how you answered in the pretest. And this is how you did in the post-test. And the correct answer, of course, is A. We just heard in the key takeaways that less than a quarter of patients under 25 years are who are eligible for PrEP receive a prescription for it. Question 2, how does cultural humility differ from cultural competency? This is how you answered in the pretest. And this is how you answered now. And the correct answer is B. Cultural humility involves ongoing self-reflection, where cultural competency involves knowing the values of different cultures in the finite way. And of course, both of them are very important. And the last question, question 3, which of the following is a contraindication to PrEP? Here's how you answered in the pretest. And here's how you answered in the post-test. And of course, the answer is C, a reactive or positive HIV test. The other answers are not an absolute contraindication. They may require additional considerations, but they're not an immediate contraindication.
Thank you, Dr. Boehringer, and thank you, Dr. Pasternak, for a wonderful presentation.
Thank you so much for having us. It's been wonderful chatting with everyone.
Thank you for the opportunity, and thank you, Dr. Boehringer.
Thank you, Dr. Pasternak.
And to our learners, thank you for watching. Please remember to complete the evaluation shown on the console to claim your education credit. For more information, contact us at info@dkbmed.com. I'm Rachel Deer with DKB Med. Thank you so much for watching. See you next time.